with great honor that we're going to introduce Professor Barbara Wilson to our audience today. And I would like to provide a few words about Barbara's accomplishments. Professor Barbara Wilson is a clinical neuropsychologist and founder of the Oliver Zanquil Center for Neuropsychological Rehabilitation in Ely, UK. She has worked in brain injury rehabilitation since the 1970s. Professor Wilson has published 26 books, over 300 journal articles and book chapters, and 8 neuropsychological tests, and she's editor of the Journal of Neuropsychological Rehabilitation. She has won many awards for her work, including 5 Lifetime Achievement Awards, the Raymond Gajal Award from the International Neuropsychiatric Association, and the M.B. Shapiro Award from the British Neuropsychological Society. She's past president of the British Neuropsychological Society and of the International Neuropsychological Society, and is currently president of the Encephalitis Society and on the management committee of the World Federation for Neurorehabilitation. Professor Wilson is a fellow of the British Psychological Society, the Academy of Medical Sciences, and the Academy of Social Sciences. She's an honorary professor at the University of Hong Kong, the University of Sydney, and the University of East Anglia, and holds honorary degrees from the University of East Anglia and the University of Córdoba in Argentina. Next to her title, you see the OBE, which is the Order of the British Empire. That's an ultimate recognition by the Queen of England for her contributions. Those of us who know Barbara, we've been inspired by her through the decades, and she continues to be very active and on the forefront of new challenges. She's doing innovative work in the area of neuropsychological rehabilitation and assessment of patients with long COVID. Unfortunately, Barbara, due to a family health emergency, is unable to join us today live. However, she did provide us with her presentation video, which we will be able to use during our conference, and which we send our warm thoughts to her and her family. So Nina now will play the Barbara's presentation. Nina?
Hello, everyone. I'm Barbara Wilson, clinical neuropsychologist, and I'm just going to start sharing my screen for you. And here we go. So today I'm going to be talking about integrating theory and practice in neuropsychological rehabilitation. I'm going to start with a case that I saw a number of years ago now, but I thought was quite an educational case for me. We actually wrote her up, Ellie, a person who lost her mind's eye. She was a 55-year-old, well-educated and talented woman who was a sculptress, and I was asked to see her for help with her memory problems. Bread and butter for me. I see these patients all the time. But she had no significant difficulties on tests of episodic memory. She wasn't like the other people referred for memory rehabilitation. I thought at first that she was just too anxious about the small decline in her abilities. And I tried to feed this back to her gently. I said, I think you're just being very anxious, but on tests of delayed memory, you're actually not too bad at all. But she insisted she had some memory problems. She wouldn't believe me. And she gave me some examples. She told me first about church windows. She said, I was in a church recently with my husband looking at these stained glass windows on either side of the church. And I said to my husband, aren't they beautiful? And they're identical. And he looked at me and said, they're not identical at all. And then she said, and I have problems getting dressed. She said, I know how to put things on, but I can't see what colors go together or what clothes work together. And then she said, I'm expecting my first grandchild and I really want this baby, but I can't see myself holding it. I can't imagine myself holding it. And she's a sculptress. She said, I can't visualize where things go. I can't sum up, draw on my fund of knowledge, and it's affecting my sculpting. And then the penny dropped and I thought, does she have a visual spatial sketchpad deficit? Now, most of you will know this working memory model of Baddeley and Hitch first appeared in 1974. And you may have seen it put out in a different way. But in the working memory part, there's a central executive aided by two subsidiary systems, the visual spatial sketchpad and the phonological loop. And we know people with, say, developmental reading disorders may have a phonological loop deficit. But I thought this woman might have a visual spatial sketchpad deficit. So I started investigating that. But it was this model that really triggered this idea. She brought in some photographs of her favorite sculpting from before this episode. She had an episode of lupus, by the way, an autoimmune disorder. These were the ones before, and these were the ones since that episode. You can see how different they are, from very detailed to very abstract. And this was her favorite piece here. And she couldn't see it, obviously, but I could. And I said, describe your favorite piece for me. And she said, one hand's on her tummy. I don't know what side she's lying on. How terrible. All the weeks I spent on it. Is one hand under her head? I suppose the knees are bent because you can't lie with them straight. Are her eyes closed? I don't know if she has short or long hair. It's not clear. It's such an effort. I live with these. They're around me all the time, and yet I couldn't draw it for you. And then of her current sculptures, she said she once put 4 legs on a man. And she said, I can't see where things come. For example, I can't think where the eyes go or where the foot goes. And I have to keep checking where the thumbs are. I can't keep working my head the way I used to. So we did a number of tests to confirm or disconfirm whether or not she had a visual spatial sketchpad deficit. Now, this is a very simple visual short-term recognition problem. You show the person a matrix for 5 seconds. This one, an easy one, got 4 squares on it. And then you show them another one, and they have to indicate either by pointing or marking which square is different. Now, with this easy bit, even people with Alzheimer's disease can do this, but my patient couldn't. She was failing at this. And the hard one, so I'll give you 5 seconds to look at that. Now, which square is different there? Well, if you want to test yourself, I can go back. If you failed that one, it may be because you're getting on a bit in years. It's age sensitive, this. But anyway, she certainly couldn't do that. Neither can people with Alzheimer's disease. But she couldn't even do the easy ones either. Now, she thought she had Alzheimer's disease, so I reassured her she didn't have Alzheimer's disease. We monitored improvement over time, encouraged compensatory approaches, which she was good at. But the point I'm trying to make here is it was that model, knowing that model of the working memory model of Baddeley and Hitch, that enabled me to predict that she might have the visual spatial sketchpad deficit. She didn't have Alzheimer's disease, and I followed her up for a few years, and she made minor improvements, but basically she had to compensate. Now, a completely different case is Gary. Gary, in 2011, was assaulted with a baseball bat and sustained several fractures, including left orbital and left temporoparietal skull fractures. He developed an acute subdural hematoma. At first, he was awake and responsive, and then he deteriorated. And a CT scan showed he had hydrocephalus and a shunt was exerted. I know the Americans say hydrocephalus, but the Brits say hydrocephalus. Anyway, that's what happened to Gary. But then he developed seizures and cellulitis over the vulve. And he had a disorder of consciousness for 19 months, a very poor prognosis. There's Gary when he first became ill. He had a craniotomy to remove a piece of bone because of his brain swelled. He's still this is when I first saw him. This is 4 months post-injury. So he was in a vegetative state at this time. His eyes were open, but he wasn't responding to things in the environment. He's having physiotherapy on the floor there because it's safer. But then he woke up after he went from the vegetative state to the minimally conscious state. Then he woke up, and from then on he moved forward fairly regularly. Here he is 10 months after he woke up, having his breakfast. He had a lot of music therapy. That's him with his mother, Wendy, who wouldn't let us give up on him at all. And he ended up walking, talking, going to college. These are some recent photos of Gary with me. And we wrote a book about him in the Survivor Stories series, Surviving Brain Damage After Assault. Now, there's a very different case from the first one I told you about. What models were used here? Well, the occupational therapists and physiotherapists said they used the biomechanical model. And treatment within the biomechanical frame of reference focuses on preventing or decreasing impairments through use of activity and exercises. To me, models of recovery were important, models and theories, of course, of learning. The biopsychosocial model, he had he had behavioral problems at one point, which were treated by the psychologist, and so forth, models of neuroplasticity, etc. So they're two very different cases. Now, I also want to tell you a bit about NeuroPage, which I still think really is atheoretical, but people said, no, they must have been using an implicit theory. I don't think they were, but anyway, let me tell you a bit about it. So NeuroPage was developed for this young man by his father, a British engineer working in California, who worked together with a neuropsychologist to develop software to drive a paging system to enable this young man to go back to college. Now, I heard them talk about this. They came to a workshop of mine, and I decided to start evaluating it. And we've done a number of evaluations of NeuroPage. It's probably the best evaluated compensatory memory system in the world. But anyway, one of our studies was a randomized control trial. And so we randomly allocated people into group A, and these were the ones going to get the pager first, and group B, who were going to go on the waiting list first. And we measured them at time 1, the baseline. This is before they got the pager. Time 2, weeks 8 and 9, and time 3, 15 and 16. Now, this is the baseline. Group A, remember, are going to get the pager first, and group B are not. These were referred by OTs, by psychologists, and self-referrals from all 4 countries in the United Kingdom. Now, there's no real difference between the 2 groups in the baseline. They had to complete a checklist on what they needed to do each day, like take their medication, feed the dog, collect their children from school, don't forget to take their glasses to work, to catch the bus, whatever they wanted to do. And we made sure that an independent person verified the checklist because these were memory impaired people. But anyway, no difference in the baseline. Then group A get the pager, go jumping up, same things are measured. Group B stay on the waiting list and don't change. Then A give the pagers back, and they do drop back a little bit, but not to baseline levels, look. And in fact, it wasn't everybody that dropped back. It was tended to be the older people and the ones with frontal lobe damage, anterior communicating artery damage. Group B, meanwhile, get the pager and they go right up. I mean, it's beautiful. These are beautiful data. And so there's evidence there, sorry, that this pager was helping people cope in everyday life, but it was developed by a British engineer working together with a neuropsychologist. And I'm still not sure whether they really had a theory or a model to work from. But we know there's lots of evidence for electronic devices to help people with memory problems. There's a television assisted prompting device, mobile phones, smartphones, Google Calendar. SenseCam, a little calendar worn around the neck, which became autographer, which became narrative clip. And now you have to get them secondhand, or you use little things on Google Glasses. And there's plenty of evidence for the success of compensations, lots for NeuroPage. We've published many papers on this, quite a few papers on SenseCam, one good one, I think, on Google Calendar, mobile and smartphones, and television-assisted prompting devices. So we know these work, and I think they're either directly or indirectly driven by theories, models of memory. So, but do models of cognitive functioning actually tell us what needs to be rehabilitated? They're certainly helpful in identifying cognitive strengths and weaknesses, and they're helpful in explaining phenomena and in making predictions about behavior. So I'm not anti these models of cognitive functioning, but I don't think, and you may argue with me, but I don't think they tell us what needs to be rehabilitated. They certainly tell us what the cognitive constraints are on any programs we wish to implement, like, is this person going to remember? Can this person read? Can this person understand? But I don't think they tell us what needs to be rehabilitated. So does this mean theories of cognitive functioning are not important? Well, of course not, because I've already talked about the influential working memory model of Baddeley and Hitch, and that enables us to understand why someone can have a normal immediate memory with major problems after a delay or distraction, your typical amnesic patient. They can help us understand why there's a difference between visual and verbal memory, or verbal and non-verbal. And they can tell us why somebody has problems with executive functioning despite having a normal phonological loop and a normal visual spatial sketch pad. But once we've established the particular problem of a person, for example, a deficit in the central executive or an inefficient delayed verbal memory, we're unlikely to set out to rehabilitate the central executive or the delayed verbal memory system. Or if we do that, we probably won't succeed. Instead, we're more likely to identify the particular problems faced by the individual with these impairments, such as problems planning a meal or failure to use a notebook. So I would suggest these are the kind of things that need to be rehabilitated. So what needs to be rehabilitated is not an impairment defined by a theoretically informed model, but a real life problem identified by the patient and his or her family. Such problems may well be caused by the cognitive deficits, but in most cases, we don't try to rehabilitate the deficit so much as the everyday problems seen as important by the patient and the family. So this is an old definition of rehabilitation, but I like this one because I think it captures what we mean by rehab. So this is McClellan, who's both a neurologist and a professor of rehab. And way back in 1991, he said, rehabilitation is a process whereby people who are disabled by injury or disease work together with professional staff, relatives, and members of the wider community to achieve their optimum physical, psychological, social, and vocational well-being. So it's not about recovery. It is about working together. It's a partnership. And this is a neurologist talking about psychological well-being way back in the early 1990s, so ahead of his time. Now, my definition of cognitive rehab, influenced by McClellan, is cognitive rehab is a process whereby people with brain injury work together with professional staff and others to remediate or alleviate cognitive deficits arising from a neurological insult. And we know that cognitive rehab can benefit people. This is Keith Cicerone, an American, who's written some important papers on rehabilitation. And him and his colleagues in 2005 said There's now a substantial body of evidence demonstrating that patients with traumatic brain injury or stroke benefit from cognitive rehab. And several studies have looked at comprehensive holistic rehab. And the findings suggest that comprehensive holistic neuropsychological rehabilitation can improve community integration, functional independence, and productivity, even for patients who are many years post-injury. And I think that's important, that last bit, because so many funders of healthcare, of rehabilitation services, at least in the UK, think you've got to do it all in a year or 2 years. And I've seen patients who've had brain injuries as children, and we're treating them as adults, and we can still make a difference. Now, neuropsychological rehabilitation, it's similar to cognitive rehab, and sometimes the two terms are used interchangeably. But I think neuropsychological rehabilitation, as I understand it, is broader. So it's concerned with the amelioration of cognitive, emotional, psychosocial, and behavioral deficits caused by an insult to the brain. And the purposes of such rehab, well, it's to enable people with disabilities to achieve their optimum level of well-being and to reduce the impact of their problems on everyday life and to help them return to their own most appropriate environments. Many of the people I work with are going to go home, most of them, but some are going to go into long-term care, some are going to go to halfway houses, and wherever they're going, we need to get them to the best level. We do not do rehab, or we should not do such rehab, to teach people to score better on tests or learn lists of words or be faster at detecting stimuli. That's not the purpose of neuropsychological rehabilitation. Now, the problems faced by survivors of brain injury, well, we know they have motor problems. These are the most likely to be understood and the most likely to get treated. They have cognitive problems, which most neuropsychologists are particularly interested in, behavior problems, sensory problems, particularly with eyesight and touch, less with hearing because of the way the brain's wired up, but we do see that sometimes. Social problems, social skills difficulties, for example, emotional problems, which certainly lots of psychologists are particularly interested in too, problems with pain, problems with fatigue, which is now a big thing in brain injury rehab. So the kinds of cognitive problems we see, memory problems, attention problems, communication problems. Some people don't put that under cognitive, but I do. Problems with planning, organization, reasoning, perception, spatial awareness, and so forth. The emotional and psychosocial problems we're likely to see, problems with anxiety, with depression, with anger, with fear, with distress, with grief, poor self-esteem, lack of confidence, and so forth. And the behavior problems, temper outbursts, shouting, swearing, physical aggression and verbal aggression, disinhibition, poor self-control, refusal to cooperate, etc. And all these are likely to be treated by clinical psychologists and neuropsychologists. But in everyday life, it's the cognitive, emotional, and behavioral problems which are often more handicapping than the physical, the motor and sensory ones. They can be compensated for. And this is quite an old quote by Kahn et al., but I like it. Cognitive and behavioral changes, difficulties maintaining personal relationships, and coping with school and work are reported by survivors as more disabling than any residual physical deficits. And as one guy said to me, I live in the ruins of my old self. And in rehab, we need to draw on a number of models and theories, or we risk bad clinical practice. If we're just sticking to one approach or one model or one theory or one framework, we're probably going to have bad clinical practice. But COVID-19 patients, and I've been seeing some of those recently, they're likely to have similar problems too as the brain injured people. Now, this is a paper that came out this year, Misra et al., looking at the frequency of neurological manifestations of COVID-19, a systematic review and meta-analysis of 350 studies. And they looked at 55 countries in all. They didn't have information on ethnicity, which we're particularly interested in because the ethnic minority groups, the Black and Asian ones, particularly in the UK, are more likely to die, more likely to get referred to neuropsychology. And in this MISRA study, they found, in this meta-analysis, they found almost 90% of cases were hospitalized, 6% weren't hospitalized, and 5% were not reported. There were 41 neurological manifestations with 24 symptoms and 17 diagnoses. 7% had dizziness, 12% headache and dizziness together, 18% smell or taste problems, 11% acute confusion and delirium, 7% disturbance of consciousness, 45% agitation, 24% neuropsychiatric problems, 5% skeletal muscle injury, and up to a third of the COVID-19 patients experienced at least one neurological manifestation. So they're all likely to get seen by neuropsychologists. Disturbance of consciousness and fatigue were associated with the severe cases. No other problems were particularly associated with severity. Mild cases were more likely to have problems with taste and smell, possibly because the more severely ill were less likely to report that. 20 studies looked at young patients, those under 18 years, and 14 studies looked at elderly people over 60 years. And in the over 60-year-olds, 34% had acute confusion or delirium, and this was associated with the increased likelihood of death, of mortality, not surprising. And of the pre-existing medical comorbidities, 26% had hypertension, 14% had diabetes, 10% cardiovascular or cerebrovascular problems, chronic obstructive pulmonary disease, 5%, chronic kidney disease, 5%, 4% had had an earlier stroke. This is quite similar to what we're finding with the St George's Hospital in London group. 4% malignancy, tumour of kind, 4% chronic liver disease. Yes, we're seeing that too, getting referred to kidney services for dialysis. But the most common neurological diagnosis was stroke. And that's true in our study as well. 2% overall, so 1 in 50 had a stroke, and that varies up to 1 in 8 to 1 in 40. You can find different numbers for that. Ischemic stroke or transient ischemic attack, only 1%. Hemorrhagic stroke, 0.31%, and cerebral venous thrombosis, 0.12%. So we're finding that too, but what I'm trying to say is the problems with some of the COVID survivors are likely to be similar to those that neuropsychologists see all the time anyway. And of course, whatever group we're seeing, whatever problem we're seeing, we need to refer to several models and theories of cognitive functioning, learning, emotion, assessment, recovery, plasticity, models and theories of compensation, linguistics, and so forth. And in future, I hope rehabilitation practitioners will draw on a wider range of theories and models. As I said, we can't just stick to one, otherwise it's going to lead to poor clinical practice. Now, this is the Y-shaped model, called because it's the shape of a Y, by Gracie, Evans and Malley, 2009. And this is used a lot at the Oliver Zangwill Centre. And we're trying to reduce the discrepancy between the the me before the stroke or TBI or encephalitis or anoxia or whatever, and the me now. So you're trying to reduce that discrepancy into the new me. That's what the Y-shaped model is all about. And in 2002, though, before that, I tried to draw all the relevant models together. It was called Towards a Comprehensive Model of Cognitive Rehab. I should have called it Neuropsychological Rehab, in the journal Neuropsychological Rehabilitation. Now, I don't try to digest this, it's far too difficult, but I put this model together in a fit of pique irritation about a very eminent academic neuropsychologist who said, you only need a good model of cognitive functioning, this bit, to do good rehab. And I thought, it's a load of rubbish. What about the patient, the family? What about premorbid personality? What about the behaviour problems they face? What about the emotional problems they face? So I put this together to try and show this person that the models he wanted were not sufficient. Now, I'm going to end this talk with a case study to illustrate this particular model to plan holistic rehabilitation for a particular patient we saw at the Oliver Zangwill Centre. So the starting point's the patient and the family. Right, well, this is Catherine. That's not her real name. I've changed it for confidentiality. But most of these bits are true. Well, the rehab program's true. Some of her details have been changed. But she was the youngest of 4 children. Her parents had divorced, but were still on friendly terms. And she'd been assaulted, severely assaulted by an ex-boyfriend. So we have to look at the nature and severity of the brain injury. Well, at the time, she had a Glasgow coma score of 8 out of 15. So that's just at the top of the group that is considered to still be in coma. A pretty severe brain injury. She also had multiple organ injuries for which she required blood transfusions, and multiple orthopedic injuries, including a fractured pelvis. You can imagine how severe this assault was. Now, early CT scans showed small subdural hematomas in both frontal lobes. So she had a cognitive assessment, and her main problems were speed of information processing, attention and concentration, memory and learning, and executive functioning. So many of the typical problems seen in somebody with a TBI. She was impaired on story recall, on word fluency and naming. But her strengths were she had good social skills, she didn't have severe behaviour problem, and she was very motivated to improve. Then she had an assessment of her mood and emotional adjustment, of course. She had very low confidence and self-esteem and was very self-critical. She actually blamed herself for the assault. If you can believe that, but she did. Now, what did she want from rehab, her and her family? And what did they expect? Well, Catherine wished to make sense of the consequences of her brain injury on her life. She wanted to study again and feel more confident in herself. Her family wanted to help her manage the psychological impact of the assault and the consequent brain injury, as well as to support her to return to a more normal life and gain a better understanding of the consequences of the brain injury themselves. Then we negotiated goals with Catherine and the family. This is one of my goals, completing the London Marathon, but that's another story. Anyway, the goals we set were understanding the consequences of her brain injury. In fact, all the Oliver Zangwill clients have that as a goal. Find strategies to support her study skills. Explore what work she could do through voluntary work opportunities. Understand her memory problems and find ways to help her remember better through compensatory aids. Feel more confident in herself and more relaxed in her mood. And develop her confidence and skills in cooking and using public transport. So she had 6 long-term goals. The long-term goals we use are those that they're going to achieve by the end of the programme, which is about 4 months long. it's usually for most people either 6 or 7 goals. Now, she went to Understanding Brain Injury Group and other psychoeducation groups. All holistic programs do both group and individual therapy, and that was true for Catherine. But she also had individual psychotherapy. With the memory work, it was looking at external aids, rehearsal strategies, and internal strategies. Strategies to manage her study skills: allow more time, reduce distractions, take in bite-sized chunks, clarify information, and repeat information. Memory, well, she gained an understanding of her memory difficulties. She went to the memory and attention group. And she said in her own words, bit telegrammatic, I think, information in, not so much as everyone else. What goes in stays in, but getting it out is really hard. So it's a problem getting information in and a problem getting it out, but once it's in there, it stays in there. She was more able to manage her memory with the notebook, but she wished to expand its use to further areas, such as remembering appointments and telephone calls. So consequently, the memory notebook strategy was developed into a more thorough memory and planning system. After detailed discussion of her needs, Catherine chose a pink filofax. I think the Americans call this a day book or date book, but we call it a filofax. And the following sections were made. She had a to-do list. She had a diary section. She had a log of her successes, a list of contacts, a shopping list section, and cooking tips. Then the integration phase. At the start, these people come 4 days a week. Then they go on to the integration phase where they're coming 2 days a week. And her main concern there was whether she wanted to or could complete a course at college. So her course tutor arranged a 1-day attendance at her previous course. And this provided Catherine with an opportunity to try out the study and the cognitive strategies she developed on the programme. Now, as our confidence goal, to increase her confidence in herself and her abilities, so she had to stop being critical of herself and blaming herself for the assault. And we use a lot of compassion-focused therapy, CFT, started by Paul Gilbert in this book, but later, this was for not brain injured people, but it was adapted for brain injured people, particularly by Fiona Ashworth. The cooking and public transport, well, a graded approach was used to build up skills and confidence in both these areas throughout the programme. And given the difficulties with interpreting written instructions, Catherine was helped to trial recipes in which the information was presented in different ways, including pictorially, because some of our patients have found pictures really helpful, or step-by-step lists with checkboxes, and short one-line instructions. And the pictures didn't really help her, but what she felt was rewriting the recipes in her own words was a good technique. Now, the public transport, well, she lacked confidence in using public transport in unfamiliar areas. She didn't come from our part of the world. She came from the West Country, and we're in the East. She feared she'd get lost. So she was accompanied on a trip to Cambridge by her occupational therapist. Now, Cambridge is a 17-minute journey from Ely, where the rehab centre is. And she was shown how to find train times, how to buy tickets, how to find the correct platform, using landmarks to navigate. And the filofax was used to support recall. And the following week, Catherine repeated the journey with her OT following. And although apprehensive, she did carry out the journey successfully and was satisfied with her performance. So we recommended that she receive ongoing support from an OT to carry on making journeys in her own local area. And we were able to arrange community OT when she was discharged. And the final challenge, before she left us was to plan, shop for and prepare lunch for the rest of her cohort. The cohorts come in groups of 4 or 5. And this task served as a vehicle for bringing together various areas of work, including use of the filofax, cooking skills, recipe adaptation, using public transport and route finding. So all the things she'd been taught were brought together for her to prepare, plan, cook this meal. She coped extremely well with a more complex recipe and displayed increased confidence compared with the early days of the programme. She sought assistance from the therapist on fewer occasions and independently problem solved more than once. She received good feedback from her fellow clients and reported feeling proud of herself for this achievement. Now for the work placement, which they have to do as part of the integration phase, this was to support Catherine in identifying possible areas of interest with regard to work or study. So we arranged for her to help out in a local clinic with elderly people. And she spent 90 minutes twice a week shadowing staff, delivering in groups and administering one-to-one exercise programs. And the feedback from the placement was very positive. They said she fitted in well, she was very personable, and she interacted pleasantly and appropriately with the staff and clients. She was actually a very nice girl, we all liked her. Then she had to evaluate the programme, but she did achieve all the goals we set. The performance was monitored throughout and the programme considered successful by Catherine and her family. We used models from memory therapy, executive rehab and psychotherapy to help Catherine use her existing skills more efficiently and compensate for her deficits. And she's currently helping out a family member with the family business for a short period of time, but she's keen to pursue living independently. Now, good practice, I've almost finished now. All these have come from theoretical approaches, but this is, if you do all these, you're doing good rehab. Sorry, provide a therapeutic milieu where patients feel safe. The goals of rehab should be meaningful and functionally relevant. Ensure shared understanding, not just between staff and patients, but between patients and patients and staff, and anybody else involved. Apply psychological interventions, particularly for the emotional problems, I think. Manage cognitive impairments through compensatory strategies and possibly retraining skills if appropriate, and work closely with families and carers. So they're the good guidelines, I think. If you follow those, you're probably doing good rehab. So in conclusion, rehabilitation makes clinical and economic sense, and there's evidence for that. We need to draw on a number of theories, different models and theories. Rehabilitation can help people compensate for, bypass or reduce their everyday problems and survive more efficiently in their own most appropriate environments. And it is possible to combine theory, scientific methodology and clinical relevance, as we showed with the NeuroPage studies, for example. People chose what they wanted to work on themselves. So I'm going to end now with 2 quotes that I particularly like. This is Arthur Schopenhauer in 1840, who said, "Compassion is the basis of morality." And my childhood hero, Nye Bevin, "Illness is neither an indulgence for which people should have to pay, nor an offence for which they should be penalised, but a misfortune, the cost of which should be shared by the community." And with that, thank you very much for your attention. Thank you.